morning, everyone. I hope we've been having interesting and informed decisions. So, without much further ado, we'll go to our next section, and I'll have the privilege to introduce Sarvesh and Sagar. Sarvesh is a director at Dimagi, a technology-focused social enterprise with over 15 years, and he has played myriad business roles across the business, government, and non-profit sector, successfully leading products and projects and teams across South Asia and Africa. Equally, Saga is a public health professional with nearly a decade of experience working with the Dimagi Child Health Campaign in Nigeria. So I have the honor to call them to the podium where they'll be talking on how the CommCare has been helping community health workers in Africa or in Nigeria. So I have the privilege to call Mr. Sarvesh and Mr. Sagar to the podium. Can we give them a round of applause as they are coming? Thank you.
Good morning, everyone. My name is Sarvesh Tewari, and I work for the company Dimagi. What we'll do is we'll today talk about our newest initiative called CommCare Connect. And we'll divide the presentation into two parts. In the first part, we'll talk about generally what CommCare Connect is. And in the second part, we'll take up one program that we have been implementing as part of CommCare Connect in Nigeria, which is focused on child health campaign. So first thing first, Dimagi has been around for almost 22 years now. We have our headquarters in the US, but we are based out of multiple countries globally. We are a social enterprise, B Corp certified, and we have deployed projects in 130 plus countries so far in this time period. Primarily, we are known for CommCare, which is our flagship platform. This is a no-code platform, which anybody who does not have coding skills can get on, develop an application. It can be a mobile application, web application, or an SMS application. What we have been doing is we have been using CommCare as a platform to develop apps which are used by frontline workers. And we work with a lot of different partners across different geographies, across different sectors, who have deployed these with the frontline workers. But before I go into the deep details of what we do, first things, I think we know fairly who frontline workers are. They primarily are the people who are working at the front lines. I think the term became very popular during COVID time when a lot of frontline workers were involved in contact tracing and case finding. Now, one thing which we don't know is what are the challenges that these frontline workers face? And we have seen since yesterday in the presentation, all community-based programs rely on some sort of either volunteer or frontline workers. So there are roughly 8 million estimated frontline workers who work across Africa and Asia. Most of them, almost 86%, and I can share the presentation, there are links which talk about where we are getting these numbers from. But almost 86% of them are non-salaried. Either they are volunteers or they have very low pay for the work that they do. And more so, the investment that we see from these programs in LMICs is more than 1 billion plus. So there is definitely a big group of people who are focusing on impact and who are doing work that is underpaid. Now, and I'll come back to this part of the presentation, but let me come to CommCare Connect, and I'll link both what I'm talking about, how CommCare Connect is linked to this. So generally with CommCare Connect, what we are trying to do is we are trying to think that if these frontline workers get additional opportunities, and these opportunities are opportunities to earn additional pay. So imagine they get on a platform, they learn a new skill set, they're already working in these communities where they have access. They learn this skill set, then they continue working in the communities in addition to what they are doing to deliver services on these new skill set. And they get verified for these services and then get paid. So technically the way we are imagining this is there is a base core layer of CommCare, which is the core platform, which I said is open source. is no-code platform, can work offline, has a lot of functionalities that can be used in this setup. Now, on top of that platform, we built this CommCare Connect platform where they can, this is an opt-in, by the way. First thing first, I think this is an opt-in for frontline workers. The whole idea is that they are already working in these communities. So they get a notification for a new opportunity. They click, yes, I want to accept this opportunity. They download a Learn application, which is a digital training platform. They get certified. If they are able to pass that minimum criteria, then they get a deliver opportunity. Now, in the deliver opportunity, they get a set of requirements. Like these are the visits that they need to do. These are the, let's say, targets that they need to achieve for a campaign. Then they get digitally verified for those services, and then through our partners, we digitally pay them. So one thing so we have been running this for roughly 2 years now, and something that has come up again and again is there is evidence that frontline workers want to learn. There is very clear evidence based on multiple surveys. There is also evidence where they have talked about how they are willing to give up pay, or there evidence about how low their salary is. There was this survey which was done in India where 15,000 workers were willing to give up their pay for just getting certified on COVID-19. And with technological advancement, we have also seen that verification has become easier, as well as there is very clear evidence around investing in frontline programs has economic benefit. So when we started seeing this evidence, we did some analysis on our own data. So what we did is we looked at 74 ANC and nutrition programs and looked at how the uptake of those programs are, what the form submission rates in those look like. And what we saw is that the top 20% were doing majority of the work. So if you see the first row, where it talks about top 20%, what a typical CommCare project looks like. So 55% work was done by the top 20%, whereas only 1% was done by the bottom 20%. And this is based on performance of how active they are on the platform. What it shows is that there is a group of frontline workers who are highly motivated, they are underpaid, and they are continuing to lead these programs, like taking the major burden of these programs. So with that in mind, we also started looking at the funding, what is available. There is a very clear funding ecosystem that is available to invest in these high impact interventions. And here are just few examples. I won't go into the details. So what we have been thinking about or looking at CommCare Connect, is CommCare Connect becomes an intermediary between the frontline workers and the government and donor on one side. So there are government and donor who don't have access to locally led organizations, who are doing impactful work, last mile work, and who are reaching out to the communities. And then there are all the challenges that I talked about, frontline workers. In addition to those challenges, there are also challenges with the organizations who work with the frontline worker. There is a low skill set problem. They don't have access to funding, even though they are doing high impactful work. And that's how we started working on the whole CommCare Connect initiative. So we got initially roughly $25 million fund from the investment by the Steel Foundation for Hope. That's how we started looking into it, conceptualizing the idea. And through different, through these last 2 years, what we have done is we have slowly and gradually scaled the program on few aspects, and on few aspects done a lot of experimental learning and looking into it. So I won't go into each detail of the timeline, but what I do want to talk about what have been the 3 learnings, and then we'll dive into a very specific child health campaign project that we have done. So what we have learned so far is that frontline workers can deliver cost-effective impact in as little as 1 to 2 hours. CommCare Connect can efficiently pay frontline workers to deliver these high-impact interventions and improve their job. So the whole idea or the theory of change that we are looking at is that improving their job will lead to improving health outcome. If the frontline workers who are bearing the most burden of our health ecosystem, they are well satisfied and well paid, it will lead to better counseling, better improvement in their job, thus better health outcome. And then the third thing is, which actually had been one of the toughest thing that we have experimented with, because we got a lot of pushback and questions around, can frontline workers with the skill set that they come, with the literacy levels they come, digitally learn something? There is a digital skill set as well. What we have seen so far is that frontline workers have been able to autonomously complete a full learn, deliver, verify, pay, which we call as LDVP cycle. Now, going into the specific details, what we have done so far is, like, when we think of high impact interventions and the experiment that we have done, we have worked on 6 different areas where frontline workers, either through a locally led organization or through the platform, have been directly registered on the platform and got certain opportunities to go and deliver those. And these 6 areas have been around child health campaign, household safety, group therapy for depression, vaccine promotion, early childhood development, and kangaroo mother care. And we have done these experiments in almost 8 African countries now. In a lot of countries, we have been working for since the start. So I think Nigeria is one of those countries where we have been working since this is the first pilot that we did. The second thing that we have learned so far is about how many people can be reached and how cost effective each of these programs could be. So if we look at the 4 key programs that we have done, when we think of group therapy, it has been very, very expensive. It has come down to roughly $100 per client group therapy sessions. But when we look at the vaccine promotion specifically promoting immunization rates, so vaccination rates for children who are under 1 year old, the cost has been $1.2 per client. And when we look at household survey has been around household safety, general cleanliness, generally a lot of things that touch upon nutrition aspects, which has come down to roughly $1.2 per client. And then the child health campaign, where we have delivered with vitamin A tablets, deworming campaigns we have run. We have delivered ORS packets, has come down to roughly $2 per visit. And so far what we have done is, this is the scale that we have reached. In few programs, we have done very few because of the cost effectiveness angle. But in some of the other programs, we have been able to scale. And our plan is, which my colleague Sagar will also talk a little bit more in detail, is to reach to 400,000 children in Nigeria in the next, I would say, 14 months. And then the last thing that we have seen is, we ran a research cohort in Malawi, where what we did is, we gave the platform to the community volunteers who were working there. We didn't tell them anything. We just said that you can go and register onto this Android application. And what we did is, a week later, we pushed out an opportunity. They had no idea what this opportunity is about. Through the platform, we were able to communicate and say that this is a new opportunity around vaccine promotion and household safety. Do you accept or not? Once people who said that they accept, they went through the whole learn, deliver, verify cycle, which means that they went onto the Learn platform, completed the learning, passed the assessment, got the certification, moved to the Deliver platform. We were able to verify that the services were actually delivered, and then they got paid for it. And the numbers that we saw was 84% of these frontline workers were able to complete this full cycle, which means that they did not need anyone's external support to do that training. So it definitely brought down the training cost by a lot. It helped us better verify that services are reaching to the right beneficiary at the right time. And then they were also getting immediately paid. So for every week's of work, they were getting payments into their mobile money account. So I'll maybe pause here, and I'll hand it over to Sagar to talk a little bit about the child health campaign, and then we can take questions.
Thanks, Sarvesh. So I think I'll talk about the specific child health campaign that we've been running across a few countries in Africa for the past few months. I think one of the key theories of change or questions that we had when we started this campaign was, are frontline workers able to deliver an intervention where vitamin A deworming, malnutrition screening, and ORS handover? Is it something which is needed within the communities, given that it's a very strong priority across countries? And secondly, is it something which can be done through a digital verification platform, and can we improve or move the needle on using CommCare Connect as a platform to improve the efficiency of these service deliveries? So our first interventions were across a few countries, mainly because we wanted to try out and see if this works across various contexts. So as Sarvesh alluded to it earlier, we had 2 pilots which we did in India, where we had a significant amount of learnings. And then we expanded to around 3 countries. One was in Kenya, the other was in Zambia, and the third was in Tanzania. Some of the key questions that we wanted to answer through this was mainly to understand if frontline workers are able to deliver these services in a short time. And some of the surprising findings that we had, even when we know that all of these programs are a strong government priority, is that there are significant gaps that exist in terms of the service delivery, the quality of the verification that occurs, and even in terms of the basic conduct of the programs. We saw a lot of frontline workers saying that there were shortages, there were stockouts, and even governments were struggling to do all of these campaigns during the Child Health Week or the Nutrition Weeks, which are kind of a staple program which are conducted across many of the LMIC countries. So we saw a definite needs gap in all of these countries. The governments have also collaborated with us later. So LiveWell in Zambia used the CommCare Connect platform later on to conduct another follow-on campaign. So we did see that this is something which is a significant need felt by governments and NGO partners, and that we could come in and fill in the gaps through this. After verifying the primary aspects of our thesis, we ran an RFP where we invited organizations from across Africa and some countries in Asia to really apply and check if we could deliver these services to around 80,000 children across a cycle of 3 or 4 months. We offered around $2 per verified service delivery, which included like the procurement costs, the pay to the FLWs, and the project management costs. And we had around 15 applicants who qualified for it, who applied to this, and we selected 2 organizations. One was in India, in the state of Jharkhand, and the second was in Nigeria, where we worked in Katsina for that. So one of the key findings were, again, in Nigeria, we ran it in Katsina, where the Andan program was pretty strongly running. But what we identified was there's a lot of gaps which occur when a service delivery like this is conducted. We were doing the vitamin E and vitamin E deworming and malnutrition screening. We found a high prevalence of malnutrition among children. But the stabilization centers that were meant to treat these children had problems in learning out. The Andan program, which has done a great job in reaching some of the hardest to reach regions in Nigeria, also had some challenges in implementing some of these programs because of the funding gaps that exist for frontline health workers. And we were able to cover a significant number of LGAs, like 2 or 3 LGAs, and saturate those with the campaign that we were running. During this time, we were also working for a scoping grant for GiveWell, where GiveWell wanted to test out this thesis if running a campaign for vitamin A deworming, malnutrition screening in Nigeria would work out, and if there's a significant gap that needs to be addressed, given that I think there's a lot of partners who are already working in this space as of now. But we are happy to know that even in Nigeria, we do see a significant opportunity to cover the gaps that exist. And we ran an RFP for organizations across Nigeria this year. We had around 35 qualified applicants. There were many more who are willing to work with this. And this is being done through a grant that we recently were awarded by GiveWell. And for the next year and a half, we will be working with these partner organizations across around 7 to 8 states across the northern parts of Nigeria. And in this, I think one of the key elements we want to try and do is really bundle a few key services. So we are doing vitamin A, we are doing deworming, we are doing ORS handover. So because ORS is something which is a low-cost commodity which can help in treating diarrhea or managing diarrhea when a child is ill with it. And in many cases, we saw that it's not something which is always easily accessible. Like a parent has to go to a health center, which is an additional cost to them. So we find that bundling of these service deliveries and creating that redundancy among the communities of these commodities is something which really helps in mitigating some of the burdens that these countries face. One of the key elements of the CommCare Connect platform and why I think we really ventured into this domain was, are we really able to verify the service deliveries that are being done through these communities? So that's something which the CommCare Connect platform is trying to build out from the very beginning. So the CommCare app that we have built has a lot of verification indicators or verification platforms to really try and make sense of whether the service delivery is being done properly or not. And of course, it's going to be a constant process to improve and build upon from what we learn in the field. We have had significant learnings of frontline workers not actually going to community, delivering services somewhere else, and reporting that they delivered services somewhere else. Not actually delivering services at all in some cases. So that's something which I think the CommCare Connect platform is going to help in terms of building up the evidence and making sure that services are reaching the communities where they are meant to be. So these are some very specific or basic indicators which we are trying to understand. So one key element where we saw during the Andron program was that the government was not really sure if a particular area had been saturated during the campaign. So CommCare Connect is trying to build out a feature where we assign a work area to a frontline worker. The frontline worker is actually supposed to go across the area. They're supposed to plan their routes. We work with the locally led organizations to plan that. And we are also able to understand if the area was saturated or not. So we are able to see if the frontline worker only visited certain portions of the community, and if the more vulnerable children who are, say, younger, who are sicker, and their mothers or parents are not able to bring them to that point of the village where the frontline worker is working. And we are also having some very strong quality checks where we're checking the duplicates based on some specific indicators like the names, the phone numbers, the family names, the GPS. And we're also allowing the locally led organizations to run these verification metrics on their own, really control the quality of the users who are doing this campaign for them. And in cases where they are not meeting the quality criteria, we're also suspending some users so that it creates a sense of accountability among the community worker programs. And I think this was one of the major pitches that we had for GiveWell in terms of improving the efficiency or the cost effectiveness of these services. Because while going to a community and conducting mass drug administration programs is definitely a very important way to reach vulnerable communities, we thought that it was increasingly important to make sure that we are actually reaching the beneficiaries we are supposed to reach. So currently, as you see, we have done work across 4 or 5 countries. Some of these programs are still ongoing. We have ongoing interest from the partners who are working with us. Currently, we have 2 partners in Nigeria who we are working with. Very soon, we'll be initiating programs with around 10 to 12 more NGOs in Nigeria, working across 8 to 10 states. And we'll be narrowing down that pool to around 4 or 5 partners. But along with that, we'll also be trying to work with GiveWell and other ecosystem partners to really expand that reach and really increase the cost effectiveness and the efficiency of these very vital programs that need to reach the most vulnerable communities in Nigeria. So I think Sarvesh alluded to this, so I won't go into too much of detail. I think 2 or 3 key elements was we wanted to really validate the platform. We wanted to validate our thesis if CommCare Connect is able to provide these services and improve the quality of these services. While also making frontline workers more able to deliver a wider bouquet of programs than they're usually trained for, while not significantly building up on the training costs that are needed for upskilling a frontline health worker. So currently we are in the process for scaling up our visits. So we'll be doing around 400,000 children in Nigeria across the next year and a half. And we hope to build upon that as we go ahead. And then what we want to do through this is build a model where a digitally led or a digitally supported platform like CommCare Connect is able to support frontline health workers to deliver impactful programs and also to increase the efficiency of the programs that are being done at the community level in Nigeria and many other LMICs. So yeah, that's mainly it from our end. We'll be happy to take any questions.
I just want to add one thing which might be helpful for folks here, which is that where you can collaborate with us are few things. One is that, as you saw in the presentation, we are in that learning experimentation mode. So we are always looking for locally led organizations to help us implement it, test out the scale model, just understand what is working, what is not working. And you saw there are like 6 areas which are across health and non-health interventions, which we have done, but we are all constantly evaluating new programs that we can create through CommCare Connect, which are high impact, which fits in the EA principles with cost effectiveness and so on. So that's one thing. I think even if you are in doubt, definitely talk to us and we can figure out a partnership or see how to implement these programs. And then the second thing is we are constantly developing new tech, which can be helpful for even not for our program, but for your program. So for instance, we recently launched an OpenAI-based chatbot where you, like as an organization, can create their own chatbots for whatever they need. So if let's say they need, I was talking to Fatima from Lafia about it, that if let's say during family planning they need a chatbot where these women can talk to the bot and ask their queries. So that's one use case. We have implemented these with adults and girls where they can talk about menstrual hygiene related questions which are a taboo in community. So anything, and we have also developed a bot around CoachBot, where the supervisors, the frontline workers don't need to be involved. There is a supervisory element so that the chatbot in the local language can help them implement a little bit of coaching there. So like in summary, there are a lot of these kind of new innovations that we are doing, and we would definitely be willing to partner and test out something that can help us scale and create more impact. So I'll stop there and maybe take some questions. Thank you.
We would like to take one question because of our time.
Thank you very much for these wonderful sessions. I'm really inspired by your presentations. Actually, we have a foundation called Life to Live project, which I am the founder of these foundations. So actually, we work on the child health mortality because within our area, I'm the student, and actually we collaborate with Enaction Nigeria, which is entrepreneurial action for us, which empowers students to carry out some project implementations which address community problems. So in Bauchi State, we actually faces child malnutrition rate, which about 510,400 children were actually facing malnutrition issues. So my question is that most of the numbers we have recorded, it is only 2 out of the 10 children are currently receiving treatment, and based on the foundation, based on the campaign we advocated, Life to Live project. So we currently provide some custard which help the children to treat most of the malnutrition children. So my question is that can we collaborate with your own CommCare Connect so that to improve the level of impact of reducing the rate of malnutrition among children within Bauchi? Because the persistent rate in the child mortality is quite top notch, and it is unmeasurable because each year, more especially in the range between June to August, that is the situation or the period in which most of the households, they are before the harvesting period. Most of the problems they used to arise within this range of June to August. Thank you very much. Thank you very much.
Thank you for the question.
For your question. Let's take one more question so you can answer everything together.
Sure.
Then the rest can direct it during the panel session.
Okay, thank you very much. So my question is simple and straightforward. Thank you for that beautiful session. So I think one of the concerns that we community health extension workers usually face is in terms of security and policies that actually protect them. So are there any policies your organizations are pushing, especially with the government, to ensure that the frontline health workers are being insured in terms of delivering their services? Because as last week, there was a case of somebody that was attacked in delivering her service. She's a doctor, actually. So are there policies to protect these people in delivering their services? Thank you very much.
Please, the rest of the questions during the panel session. Thank you.
So I think for the first question, absolutely, we look for organizations like yours to work with, because the reason we want to work with locally led organization is they know the context, they have access to the community, and they work in the last mile where we can't go with our health workers. So that is one primary reason, but also because we do through this whole initiative want to upskill the frontline workers, but also the organizations, so that they can, with that skill set, be able to apply for RFPs with bigger funders and where they might not have access to, but also through the platform have access to that kind of funding. So I think recently we are going to, not recently, in fact, tomorrow we are going to meet roughly 12 organizations whom we have finalized out of the 36 RFP that Sagar was talking about. which will be focused on exactly the same area that you mentioned. So I can share my email and we can be in touch, and we can definitely figure out a collaboration for any of the programs that we are working. And we do work in roughly, I would say at least 6 to 7 states, but we have worked in all across Nigeria. So I think geography won't be a problem for us if it works for the organization. And so as for the second question, I think that's a very important question and something which we have been thinking about as well, which is there are a few aspects of the kind of support. One is that in terms of advocacy, so to answer straight away your question, we don't get involved in the advocacy directly, but what we are right now doing is we have been only working on this for the 2 years, and I think we don't have enough evidence to fruitfully do any kind of solid advocacy. So what we have been prioritizing right now is first of all about pay. So right now when we design a program, we make sure that it is a local organization that is the implementing partner who understand the security concern. And if an area is risky, right now at least we don't have a solution for it, so we are not implementing in a risky area where there could be impact to them. Now, in some countries, like I'll give you South Africa example, there certain communities are risky, where petty crimes are common, and so if health workers are going there with a digital device, it is likely that their phone might be get snatched, their purse or wallet might be get snatched. So there, they already know those communities. They have started to do different interventions or ideas. So for instance, they go in pair, which means that if there are 2 people, then they can handle the situation better. They involve local faith-based organizations or from the local mosque or the churches, community leaders are involved there. So they do a sensitization before these volunteers or these frontline workers go into the community. So that is the safety aspect of it. I think what right now we are prioritizing and focusing on is advocacy around pay. I think probably you all know that Nigeria recently increased the pay for frontline work. And I think those kind of things are what we are right now focusing on, that even if we don't go to the unsafe areas, there is still a lot of risk for day-to-day livelihood. And first thing that we are advocating for through different organizations is to get a minimum viable pay, like minimum wage that is a valid wage that can create impact, but not at the expense of frontline worker. So that's what we have done so far.
All right, thank you very much for this session.